might just about have to have one of those rugged cases on it. And then sometimes the person's partner or family member will be in there and they're like, what are you talking about? That doesn't bother me at all. Okay? Now, keep in mind, it doesn't require a brain injury for this to bother somebody. If somebody just gets headaches and migraines, even without a head injury, but vision is one of their triggers, this will feel like it triggers symptoms. Same with dizziness. Here's what it looks like, and some of you may want to feel free to close your eyes if you don't like it, but it looks like that. Okay? So yeah, you can see lots of people in the room where like, get that out of my face. But it's a great test for that. And that's actually one of those things that in the little project we were starting with UVic, if you put a lens in front of somebody's eyes that makes it so that doesn't bother them as much to look at, so maybe it goes from like a 10 on the terrible scale to like a 6, you can actually measure a change in how their brain is working to process that information that aligns with the person's subjective change. So they'll say, oh, that doesn't feel as bad. And then at the same time, you'll actually see that it's not registering the same way. Now, if you think you have these issues, or if there's something going on there, or you have family members who live somewhere else who do have these problems, here's what you want to do. You want to find an optometrist who's got training and skills in this area. And I can promise you, we do not really come out of school with this. Okay? So it's got to be somebody who's really taken an interest in it. It's also not an easy area to work in. All right? It is much easier to just go to work and better 1 or 2, your eye is healthy, here's your prescription, maybe you have dry eye. That part is much easier. And so not everybody wants to work in this area either. And some of you may have found that frustrating sometimes, because if you do go to an eye exam and you're struggling with some of these things, there's a lot of eye doctors who will get very flustered or have a hard time with it because they don't really know what to do. So you want to find somebody with training in binocular vision dysfunction and or functional vision. Now there's a number of different places they can get training from, which can sometimes dictate how effective they will be for you. You want to ask for specific testing. So the best thing would be think binocular vision. You want to make sure specific testing is done. This includes eye tracking. And I'm really sorry for the small print. I did not think it would show up this small like that. It's not just trying to make people think they need glasses. But you want to ask for specific testing. For example, eye tracking. Most eye exams don't look at how well people's eyes can track. You want to look at how the eyes and inner ear work together. Okay? When we give you a prescription for clearness, sometimes that prescription can help your clarity. Sometimes it can accidentally disrupt how your eyes and inner ear work together. So it's important when a prescription's given to you that they're testing, okay, how does this actually impact your eyes under conditions of head movement? Does it make you more dizzy or not? How many of you in here have had glasses before that have made you feel dizzy? Right? Yeah, and that's because it can cause a disruption sometimes. Binocular function. You want to make sure they're really looking at how well your eyes work together as well. Okay, and it's not just a question of is it double or not, or just a simple convergence thing. They really need to dig into how much stability do your eyes work together. And then the other areas like depth perception. Now, if these problems are identified during an eye exam, there's going to be some things that can be done for treatment. And this is what you also want to ask about, and often before even an appointment. Because if the place doesn't offer you treatment for anything, then, it's going to be hard to get what you need. So there are specialized glasses and lenses that can be used to help change depth perception, to help change how the eyes work together. And sometimes there's specific tints that can really help. Now, a quick word on tints. Tints are very individual specific, okay? So just because there's a study that shows that, hey, this tint helps with migraines does not mean it will help you with your migraines. So when it comes to tints and things like that, it's very important that you get a chance to try it. And how you select your tint is generally based on, honestly, get in touch with yourself and how does it feel. If you're in a bright room and that tint goes, okay, we're looking at a screen and that tint, that's a good tint. And you compare it through several other ones, okay? Because one of the problems sometimes is that there will be money put into studying certain tints because there's a patent behind it, okay? For some tints, there's no patent behind it, okay? A lot of people aren't going to fund any studies for that because there isn't any money to be made on the back end of it. So for tints, it's not necessarily a one-size-fits-all, and there is some testing sort of required, and I say that because I've seen people waste a lot of money on tints that are supposed to help with migraine, but it doesn't help that person because it's not what their system needs. right? Here's a great example. So that's Joan. She's walking and trying to move her head side to side. So her instructions were walk down the hall, but move your head while you walk. Not easy. Now, what nobody realized was that her glasses, while they were clear, they were messing with her depth perception. And if you watch what happens here, they don't mess with her depth perception. She can walk and move her head. Okay? She also stopped falling all the time. Oh, that's me talking. I didn't realize that part was in the video. She also stopped falling all the time too, because that poor depth perception was putting her off balance and making her more likely to fall. So that was a great example of where she'd been given good glasses, bought them from an expensive place, but nobody paid attention to the fact that they were actually messing with her depth perception, or at least not helping it in any meaningful way. Actually, this is a great one because you can watch her here too. She's so lovely. So turns, and you can see she loses her balance as she turns.
Yeah.
Now, if we give her something where her brain can use her vision to help her orientation and her balance,
How do you know
she can
what
turn.
lens to put on her?
You measure the deficiencies, and then you can use it. So it's almost like, it's like if I knew that somebody drew the line 2 inches too short every time they drew it, I could trick them into drawing it 2 inches longer by changing that. So it's like if you're, if you can measure, okay, every time you move your head, your brain misjudges it by this much, you can change components in the lens to kind of assist that.
My bad knee, I found that if I went for a walk up my hill at night and then back down again, it took some of the pain away. It's been a long haul. However, one of the things I recognized was that sometimes in the evening when I'm tired, I take my glasses off and I don't read and I don't watch TV. I'm just in my chair rock. And I would go out with the dog because the dog wanted to go out, and then I'd walk up my hill, and on the way back down again, I realized, okay, it's clear enough the stars are out. And so I would look at the stars, and then I'd look for the moon, and the moon would be, what shape is that? Like multiplications of itself. And so I was standing out in the street doing this, trying to find where I could make the moon be just one.
Yeah.
And I found that if I did that with stop signs and traffic lights, I could do that too.
So the very interesting part there is, if your eyes are having trouble working together, oftentimes you can find, for some people, not everyone, you can find a different head position where the eyes have less of a problem working together. So one common thing, if somebody has a vertical misalignment between their eyes, if one eye wants to drift a little higher than the other one, they can often compensate for that by tilting their head a little bit. And it's really funny when that person's in the chair and you go, is one side of your neck a lot tighter than the other side? And they're like, how did you know? And it's like, well, because I know that you're always going to be tilting your head like this to try to level your two eyes out so that they work better together, and that's going to wreak havoc on the one side of your neck. Okay, so what you're doing there is really cool because your eyes are having trouble lining up with each other, and you're sort of hunting around to find the place, where they can actually sort of overlap. It's kind of like if I had two clear pieces of acetate, or if you had a pair of loose binoculars and you're sort of trying to adjust them in such a way so that the two images overlap properly. That's really what she's describing, is that feeling. Other treatments for these things. Vision therapy can be one, much like vestibular therapy or retraining the inner ear. You can retrain how the visual system works. And it's not about retraining muscles. It's not about fixing the physical eye. You often have to change how the brain's coordinating the eyes and then how it's processing the vision too. And those are things that are treatable. For some people, you can treat it and you get full resolution. For other people, you don't get full resolution, but usually you can make it at least a lot better than it was. Okay? And it can also depend on some other factors that play into it too. Like most other things, it's not always there's no sort of panacea or no thing that's always the perfect one treatment for everything. The goal is to treat all of the things that are kind of in the way. But really good vision therapy too, if any of you ever undertake that at any point, it's also not about just repeating exercises either, because it's not about strengthening things. And it's amazing, and I know this because earlier on in my career, I did treatment that was way less effective with people because we thought it was about do this activity and repeat the activity until you can do it well. Instead of using the activity like a feedback loop to help teach the person's brain a better way to do that thing, and then they start to learn that as a default. And so it's a completely different approach to it, rather than just, here, do it and do more, and then sometimes you're repeating a bad way to do it. It's almost like if somebody has a stroke and literally forgets how to walk and they've got to relearn how to walk, you want to repattern the movements in proper, meaningful ways, rather than just like, okay, just keep practicing walking. Because then often in those cases, they relearn their gait not in a great way. It's not just about repeating. If any of you are also in that situation, and what we tell all of our patients is, generally if you're working on a specific activity, within 1 to 2 weeks, you should be seeing meaningful improvement in either symptoms or function during the activity, showing that the system is learning how to do it better. And if not, then it needs to be done differently, or there's something else that needs to be addressed. And I say that simply because I've had many, many people say, I've been given these visual activities to work on, I've been doing the same things for 6 months, and it's not improving at all. And then I generally look at it and I'm like, to me, that feels like the definition of insanity. And again, that's how, I mean, we didn't know how to do what we do now 5 years ago, 6 years ago, things progress. But when we look at it that way, in the world of rehab and rehabbing the visual system, if we're not seeing progression within a week or two, it usually means that it's not the correct thing that's being worked on, and or not in the correct way, and or there's something else in the way of that, okay? So sometimes it could be, I just had a patient this morning. We actually couldn't really make a lot of ground with getting his vision working better until the migraine doc I work with had some of his migraine stuff under control. Because his migraines would be so easily triggered, we actually couldn't meaningfully do the work that we needed to. Now that that's been under control, we've actually made a ton of progress. I've seen the same with people's necks, with their inner ear. I've seen it with people's iron levels, other stuff like that too. So there can be more than one thing in there, but it's just important for you guys to know.
Iron levels?
If people are anemic, everything is worse. Couple of other key considerations I want you to all really be aware of with this, and these are things that could hold anyone up within treating these visual functions. Contact lenses. If anybody's wearing a multifocal contact lens, which means a contact lens that is supposed to let you see at different distances, that can really disturb balance, dizziness, cognitive fatigue, and many other things. Or monovision is also a problem. If they put one eye at close and one eye at far, that is not natural for the human visual system. It distorts and disrupts a lot of cues that the brain needs for depth and spatial processing.
Yeah, people do that with their cataract lenses.
Yep, and I would give the advice to anyone you know not to do that. Okay? Now, it causes a lot of issues. It doesn't always cause them right away. Now, if somebody's already done that, there are ways to still help them. One of my friends had that done. He was having a terrible time driving at night. He just thought he hated Teslas. Okay? But with one eye all blurry at night and the other one clear, his brain was having a heck of a time figuring it out. So he has a pair of glasses he uses at night in the car when he drives. And now, all of a sudden, he's like, I feel safe again. He's like, it doesn't drive me crazy. So, and the same thing, he was getting so tired by the end of the workday. He could see his computer screen clear, but one eye was still focused for distance, one eye was focused at his computer. It's like listening to competing music in each ear. So, in his situation, he also has a pair of glasses he puts on when he sits at the computer, and his focus is way better and he's way less tired, and apparently less irritable, says his wife. Cataract surgery, so what you just talked about, my advice to people always for cataract surgery, get both eyes done at distance, and then you have to wear reading glasses for up close stuff. It's not a big deal.
I know.
Now,
I did the opposite. It's so stupid.
Well, for some people, and I do have some people where I'll tell them get both eyes done up close. Like my mom, for example.
Yeah.
She's perfectly nearsighted up close, and she's really happy with that in her life. So for her, for cataract surgery, she'll probably do better having them do that, because that's what she's used to.
Yeah, but mine, I got double vision now.
Yeah, and that can be caused sometimes by monovision, sometimes by multifocal stuff, sometimes by the eye muscles being impacted too. So it's really important for anyone who's had a brain injury to be very careful of monovision contact lenses, multifocal contact lenses, and or when cataract surgery is done, it really needs to be done with both eyes together. Because
both eyes done at the same time?
No, they won't usually do them at the same time. I mean, both eyes at the same distance. So have both of your eyes done so they work together,
I
rather
see.
than one close and one far, or the multifocal lenses. Because after brain injury, a lot of people have visual systems that don't work the way that they used to, and they're not as resilient, and they have a harder time with some of that change, and it can make for way worse symptoms after cataract surgery if it's done with monovision or multifocal or any of those things.
So are you saying that people shouldn't have multifocals just if they've had a brain injury, or anybody?
Personally, I wouldn't put, so I always explain the pros and cons to people of that. The challenge is that the human brain's made to have one depth in focus at a time. Part of how our brain understands depth is that. And with the multifocal lenses, it creates a very unnatural visual image on the back of the eye. And yes, for the sake of convenience, but the ramifications of that in terms of, balance, fatigue, reading performance, and other things, the majority of my patients who've had that done wish that they didn't. And there's a lot of potential problems that can come because of it. So my advice from a visual performance standpoint is always both eyes done at distance, don't do the multifocal side of things.
Because then you can use cheaters.
Yeah, exactly. And cheaters or sometimes people will require specialized prescriptions that help the eyes work together even better than cheaters too. And they keep cheaters everywhere.
What they did to me, if I lose my glasses, I'm screwed.
Yeah.
But if I had gone long distance where you don't need lenses in long distance, then you just go to a store and buy cheaters.
Yeah, it'd be a lot less frustrating.
Cheaters, what are cheaters?
Oh, he's referring, so when speaking of cheaters, he's referring to like drugstore readers,
really?
just sort of the magnifying ones. Yeah.
Oh.
Now, that said, when it comes to things like that, so for example, for my dad, he's had cataract surgery, both of his eyes are at distance. He can use drugstore magnifying glasses when he's got to see a text message quickly or things like that. But if he's actually going to sit and do computer work or read or focus, his concentration, his reading speed, his fatigue, and all of that is much better if he uses a lens that's designed to help his eyes work together. So I kind of joke with him and I say, Dad, you know what? The cheaters are they're like the shoes that don't fit you perfectly at the door. If you're taking the garbage out in them, they're totally fine. Doesn't really matter. But if you're going to go on a big hike or a big walk, wear your shoes that fit you, that are made for your feet and how they work. And that's kind of a little bit of an aside.
No, totally agree with you. Good distance.
Are you saying if you have problems with your vision, that causes fatigue?
Yeah, problems with your vision can cause fatigue. Yeah.
Because inner ear, certain foods cause fatigue.
Absolutely, absolutely, and there's so many different things that can pile on to fatigue too.
Yeah.
I kind of joke with people, it's like migraines. There's many things that can fill the migraine cup, and you get the migraine when the cup is too full. And then the whole goal is going, how do we reduce some of those things in the cup so that you have more bandwidth for the other ones? But what I want you to remember from tonight, really the key takeaways, your vision is about more than clarity. So when you do go have those things tested, or a loved one does, please make sure that they're checking a lot more than just clarity. And if you or someone you love is struggling with these things, get those things tested and get to know your local experts. There are different eye doctors who will have different approaches for these things too. And it's important that you get to know them and feel comfortable.
So you don't have to go all the way to Victoria to see you?
No.
Okay,
No.
you have a...
There's a number of us on the island actually too.
Okay.
So I've got an office in Nanaimo and one in Victoria.
All right.
Simply because I had a bunch of patients gang up on me about 5 years ago and tell me they were tired of going
But
to Victoria.
you are totally different. You are different than the woman on Waddington.
She's fantastic, and we do take different approaches for sure.
Okay.
So she's probably helped some people that I couldn't, and probably vice versa.
Yeah, so if
So
you
it's
got
actually
problems,
nice having different
just
approaches.
keep opening doors.
Entirely, yeah, and you get to kind of find what works for you.
Yeah.
But yeah, that's where you can kind of get to know people that way.
Where's your office in Nanaimo?
We're on Bowen Road.
Oh, I know where.
Yeah, and the other thing I'd say with that too, what is important on that note, and it's actually really important in this world, the amount of people that I've had come into my office with a bag of glasses that hasn't worked and a lot of wasted money.
Yeah.
It's when you're gonna work with somewhere, ask them what their policies are on things if glasses don't work for you, or if like a prescription doesn't work, because nobody's perfect that way. Cases are complicated.
Yeah.
There's multiple times that I often have to reorder lenses for people or things like that because they respond a little bit differently to it than we thought out of the gate. Now, the last thing you want to do is end up doing that somewhere where they're going to charge you on every single iteration, or if it doesn't work, you're stuck with that. So always just ask about those kind of policies too.
So do you think you see this going to grow everywhere, all across the country?
It is actually. There's a lot more optometrists getting involved in this.
Okay.
And a lot of my friends from my graduating year, once I got into this and got very vocal about it, a lot of other people started learning more and
Can
more.
you do eye
So we're
surgery then
teaching.
too?
Nope.
Okay.
No. Thankfully, I don't really want to do eye surgery.
Yeah.
I mean, it's so funny. Like for me,
No.
I love my interactions with people all day
I
long.
understand.
The thing that brings me the most
Yeah.
joy is actually interacting with people and having them see improvement. That's what brings me joy.
Yeah.
I think the challenge for surgery is I've got a few friends who are surgeons and they spend most of their day just doing surgery.
Yeah, no,
not my jam.
but again, you're not there's different.
Yeah.
reading
So for
about-
surgeon, you go through med school
Yeah,
first and then you do
exactly,
surgery.
yeah.
We exist much more on the functional side.
Yeah. Cool.
But I thought I could open up the floor to a few specific questions, stuff like that for anybody as well. Yes.
I had, when I was a little girl, I had goggles, and it was because I had one lazy eye.
Yeah.
And so when I first had my brain injury, I got my little girl glasses
Yeah.
out of the box,
Yeah.
and I put them on, and I could actually see better with them
Yeah.
than not. But going to my eye doctor and getting my prescription, the only thing that makes me uncomfortable is when the lenses themselves are from a different company.
Yeah. So a lot of the time, so here's the challenge. When people make glasses, a lot of the time they don't realize how small differences in how they're manufactured or in how the lenses are designed can completely change the person's experience with the lenses. And different companies have different default ways of doing it. And most optometry clinics don't control for those things when they order them. They leave a lot up to the company that manufactures it because we're not taught that it matters. And so that's one of the things that you'd likely face is there's one company or one lens designer or one thing that works better with your system.
Yeah.
But nobody's probably identified exactly why that is. So I'll get people where they're like, I can only wear Nikon lenses. And it's actually just because the way that Nikon does their lenses actually works for that person's system.
Yeah.
And it actually has nothing to do with Nikon itself. It's just like the way they modify their design works better for that person. But if you know what's actually happening there, you could order different lenses and different things using the same variables and they'd be just as happy, if not happier. So it's really a question of optics. That's usually what that is.
So you've helped a lot of people with apnea attacks then?
Not necessarily. Maybe people with apnea and vision issues. But
Yeah, that's
I
what
can't
I
help with
meant.
apnea. Yeah.
That's what I meant, that's where my double vision came from.
Yeah,
And
so
that's my-
often double might be caused from that.
Yeah,
And despite the apnea, you can often still give the person something that will help reduce the double
okay, yeah. 'Cause this
significantly.
is-
It's not fun.
Yeah.
Question?
As a child, I was playing ball, and I was running to catch the ball and ran into someone's forehead, broke my nose and all that. And then when you were advertising, you said something about brain injury can cause vision, because my family doesn't wear glasses.
Yep.
But I've worn them since I was a kid. Could that do that kind of damage?
Yeah, so a lot of the time the reason why people become nearsighted or get prescriptions in the first place for that is often because of us straining our eyes. Okay? If you look at it from an evolutionary standpoint, there's no evolutionary advantage to losing your distance vision. You'd be the first one eaten. Okay? You couldn't see the predators and you couldn't forage for food that well. Right? Maybe you're the one in the tribe who takes splinters out of people's feet, but that's about it. So really where a lot of prescription problems come from is from strain from up close stuff. And sometimes when people's eyes don't work as well together after an injury, their eyes can strain more from that. And that can, if they're genetically predispositioned, it can also cause more nearsightedness. So yeah, it is the case.
I'm the only one in the family that had to wear glasses.
Yeah, it's not purely a genetic thing like familial either. So that may have played a role in it, for sure.
I'm just wondering.
Yeah, it's a good
because-
question. Yeah.
My question is about the amount of time that should be given after a TBI
Yeah.
before vision therapy is introduced. If someone had a very traumatic injury
Yeah.
where there was severe impact,
Yeah.
and it was 3 months ago,
Yeah.
they've been at ICU,
Yeah.
trauma ward,
Yeah.
the rehab center, and now they are with family recovering,
Yeah.
double vision. They have an appointment to go and see some type of optometrist, but the double vision is creating migraines.
Yeah.
And can vision therapy be introduced now, or do they have to wait? Because the whole
That's actually
brain
a
injury
really
thing,
good question.
the brain injury is about waiting,
Yeah.
right? Everything has to be waiting.
I'd say yes and no, and I'm really happy you asked that. It's a little bit case specific, but what I've learned throughout the years is that, if you take a situation like that, usually what you want to do is go, how can we help the person the most given their situation? So I've seen patients where we've got a really severe case and maybe a lot of other things going on that are like sort of front and center, especially if there's been a lot of injury. I can think of one patient where it was like severely broken back and neck, okay? But she was also getting migraines, trying to read, trying to study, trying to keep herself busy while she couldn't do a lot of her other things. And so in her case, we were actually able to give her specialized lenses that reduced her migraine frequency by about 50% and allowed her to do a lot more reading. She could talk to her friends on the phone, she could do all that stuff. So it's a little bit case specific, but most of the newer literature, what it really points to is that you want to be engaging and active in the rehab efforts that you can be, rather than necessarily just waiting completely. While at the same time not doing things that are gonna flare or trigger it too much too. Because the other thing, and this was a mistake that I used to make very early in my career, was sometimes in treating things, it might be more than that person's sensory system can handle, and then you end up sending it into more fight or flight, and that's very common in a lot of head injury rehab programs where it's like, hey, reading causes this person significant distress and migraines and stuff, and they're like, great, well, we're gonna practice more reading. And it's like, and all you do is spike the person's symptoms, and then it makes the whole thing worse. So in a case like that, the first thing you'd usually look at is going, hey, is there a way we can use specialized glasses or lenses to reduce the load on their visual system, to take some of that burden off of them right now, so that they're not getting the doubling? Because I can promise you that'll be related to the headache and migraine component too. So you go, how do we reduce that burden on them overall? And then on a case-by-case basis, you'd go, okay, when does this person have the capacity to start doing some of the therapy things that'll benefit them? And depending on other variables, might be soon, might turn out that's in 6 months or something like that down the road, when sometimes other things have been looked after too. Because there are certain, again, if I go back to the case of the back and the neck part of it, that person was not ready to do any of the things required for their visual therapy until a lot of the other stuff was addressed.
Yeah.
But the right glasses and lenses made a huge improvement to her quality of life in the meantime, and a big reduction to her symptoms.
Yeah,
but
and right now
you-
they're just in the queue waiting for that appointment.
Yeah,
And it's that waiting that is just agony because,
the waiting's hard because you need help.
yeah, they,
You know.
the walking down the stairs, all the things that you mentioned
Yeah.
are so difficult. So yeah, well, thank you.
Definitely make sure to get them on a cancellation list too. Usually for most places, if you kind of poke and prod for stuff like that.
Mhm.
Yeah.
Okay.
I've been waiting for a neuro-ophthalmologist.
Oh, neuro-ophthalmology, yeah.
Is that this? is
Neuro-ophthalmology, depending on who you see, often not as much on the functional side of things.
Okay.
Very, very good at dealing with any disease underneath it, recommendations around treating the pathology, any of that stuff, like experts in that area. Not often as much trained in the use of lenses for reducing double vision and other parts
Yeah,
of that.
see, I'm
too.
a 24-year stage 4 lung cancer survivor with 10 rounds of whole brain radiation. I'm an anomaly, right?
Yeah,
And a lot of doctors don't even know what to do with me.
no,
I get SMART syndrome 4 times a month. That's, are you familiar with it?
I'm not,
Yeah.
but we'll have to get into that at some
Yeah.
point too. Just before we do, I just wanted to check and see, another question.
Sorry, I just have a question. I haven't had a chance to read your book yet. We got it at the Nanaimo Brain Injury Society, but with the coexisting conditions like ADHD and dyslexia and whatnot, does that contribute to
So
faculty?
it's actually a really good question.
Yeah.
When you look at dyslexia, for example, and this was relevant to 2 people I saw earlier this week, and actually my own family members. When dyslexia is diagnosed, technically they should rule out all the eye tracking and issues and stuff too. In reality, that's often not tested. So you're gonna have a population of people who've been diagnosed with dyslexia who also have eye tracking difficulties as part of the problem. You often don't know how much of the problem it is until it's treated, because if you look at it like a river, the information has to pass through the vision before it gets to the parts of the brain involved in dyslexia. Now, then there are cases of dyslexia, like one of my very good friends, he has no vision issues whatsoever. I was all excited. I'm like, oh dude, there's like an 80% chance I can help you with some of this. Tested all this stuff, there's nothing going on. And I was like, all right, I got nothing for you. Same with ADHD. When one of the studies actually in the slideshow, if you take kids who have ADHD symptoms who score high on it, and then you select the ones that have trouble with how their eyes work together, like me, and you treat that, they score lower. Doesn't mean it all goes away. You're allowed to have both things, but there is an overlap in symptoms between the two. Now, what I see clinically is if I get a person in my chair who's suffering with some of this stuff after injury, and I'm like, I got the odd one like this morning where I was like, how was your reading in school before all of this happened? And it was like, oh, I was never really a good reader in school. And so we had an unstable visual system that was then made worse during injury. And that's actually really common. And there's a huge overlap in symptoms too, which is where people are often like, I feel like, it's really common for me to hear, I feel like I have dyslexia after my brain injury. or my ADHD symptoms are way worse after my brain injury, because it can affect some of the visual mechanisms that can cause some of the same things.
Potentiates it.
Yeah,
through-
yeah, it adds to it.
Yeah.
Yeah.
Sorry, just one more.
Yeah.
With a dyslexia diagnosis, like my son, would you recommend having them tested?
You usually always want to assess the eye tracking and other stuff. I
Okay.
mean, I did that with my niece, and it turned out that, I mean, what are we, 2 years later, she's caught up. So her eye tracking stuff was severe enough that, you know, she wasn't recognizing words, because to her it looked like a brand new word the next time she saw it. Her visual memory wasn't working properly, so spelling was really hard, because the way that we spell is we use our visual memory. We have an internal picture of a word, and that's what we spell from. We don't spell from sound, otherwise it'd be all phonetic, and that doesn't work very well.
Sorry, I didn't mean to sidetrack it.
No, no, no.
Separately,
That's an area of my
separately,
passion, so it's like I can talk about that all day.
Yeah, okay,
Yeah.
thank you very much.
You're very welcome.
I appreciated you talking about different provinces, and my sister, I don't wanna get into too much of it, but, anyways, ended up having a brain tumor and meningioma, and so now we're about a year and a bit out. So I'm thinking, okay, how can she get involved? Who can she find? Is there an association or?
Yes, the association standards are a little bit like, again, you'll still want to do your homework on whoever you see. If she's in the greater Toronto area, I know a couple of people I can like trust. Same with
Manitoba,
Kelowna.
Actually.
What, beg your pardon?
Manitoba.
Manitoba. Don't know anybody in Manitoba personally, but there is a Canadian Vision Therapy Association, so there are people who will register with them. But again, same thing. I'd say just, you know, do your homework, have her do her homework on places, and
Who invented this?
there's aspects of it that have been around for a long time. Now, earlier in my career, one of the things that I found is there's different places that teach different approaches to vision therapy. And like many things, one of the challenges is that a lot of them are very siloed, and they're very sort of stuck in their own ways of doing it. And so my approach, what I, you know, again, coming from the engineering side, is I went to go learn here, and I went to go learn here, and then I went to go learn here, and then I started piecing things together in the ways that made the most sense to me. And then I'm very stubborn. So also, if I had a patient or a case where it's like I couldn't really figure things out, I'd often just keep working at things and trying to figure out what was underneath all of it until we got there. The reason that I learned how lenses can affect depth and spatial perception way more so than what's taught is actually because of a couple of stubborn patient cases where I'm like, there has to be a reason why this worked and this didn't, and this isn't working this time. And that's what led us to kind of discover some of those things. So in some ways, the way that our clinic practices and our own R&D is really a culmination of a lot of different areas in our own experience that we put
Do you qualify
together.
for any insurance companies?
Sometimes, yeah, it just depends.
Yeah.
So, yeah. Any other, yeah, question?
Kind of a tag off of an earlier question. Is there ever a concern in somebody after post-injury coming in too early? How
So
do you, like,
what I tell like Rugby Canada, for example, is usually if it's in the first 2 to 3 weeks, which is the acute period, like real swelling side of things, then I'm like, that's often too early to know what the person is going to be left with. Because what I'm often interested in, now that depends. If it's a student and they've got exams coming up, I would love to be able to write them a prescription for glasses that can help them get through exams so that they don't have to defer everything to the next semester. But if we're really going, okay, what are the long-term things that are not going to get better on their own, then it's often after that acute phase, which is kind of like 3 to 4 weeks.
Are you Rugby Canada?
Not me, no, but I've worked with athletes from all sorts of different associations.
You look like you.
Yeah, maybe, that's just, yeah. But does that make sense?
Yeah.
Yeah, so it's kind of after that acute part, but at the same time, you often want to see, well, how do we at least help the person in the meantime? How do we help them with their quality of life and the things that they can do right now? But there is also an issue with sometimes giving treatment, whether it's vestibular physio or whether it's vision therapy stuff, if it's done when the person's nervous system isn't totally ready for it, or there's things that are missing, it can sometimes just drive symptoms worse. So I will see patients if they have problems with how their eyes work together and they're doing a lot of vestibular rehab that needs their eyes to work together in order to do it, sometimes it just brings their symptoms way up without making meaningful improvement. Now on the flip side of that, if I have a patient and we're trying to do vision things under conditions of head movement and they've got a really bad neck issue, guess what? The neck's gonna get in the way of my work. So there's sort of all these systems that we have to consider, and it's really about making sure that the person has the capabilities to engage in treatment properly too.
And when they're healing, what they're doing with that healing time, that I would imagine has an impact too. Like if they are, like you said, overdoing their brain activity with certain activities, that could actually
And it's
slow
how
things
you-
down. But what if they're on the computer a lot, or what if they're watching shows because they can't really do much else? So
Yeah.
is that?
It's so hard. We often give patients this brilliant system called the Parkwood's Points pacing system, because what it helps people understand is that it's almost like it's like having only so many coins that you can spend a day of activity, and certain things will drive it different amounts. And a lot of people don't realize that, yes, maybe the only thing that they can kind of do is to watch the shows for that, but that's going to drive their symptoms way more than listening to an audiobook. And so, it's kind of like, are you spending your available energy on things that get you better, or are you spending your available energy on things that entertain? And where do you spend it? So I've had patients where it's like, hey, you know what? You have this many basically points a day before your system goes into overload. Here's the things you can spend your points on. Wouldn't it be nicer to spend 5 points on your social contact where you feel a meaningful relationship than to spend those 5 points on TikTok? Or wouldn't it be better to spend 3 of those points doing your physio exercises for your neck, because that's going to physically help you, than to spend 3 of those points doing this other thing over here? And it helps people start to kind of understand where they're using their capacity, and to use it in the more meaningful ways for that too. So it's a good question. Yeah.
I think what I'm hearing, if I understand, is kind of like people trying to describe where's like the tolerance threshold of like what is doing harm and what is challenging you enough, which is going to be very particular to each person. I know myself, right out of the bat, right after my accident, and my recovery is also fluid, so maybe what I could have handled a month ago, I might be struggling with today, so it's very individual to that time. But also when you were talking about like coins and stuff and your energy, there's something called spoon theory, like do I have enough spoons for this and that sort of stuff. But when I first started, my vision issues were so bad that my physiotherapist was like, okay, what is an accommodation versus actually strengthening your brain? And at the time, my tolerance was so low, any sort of light and stuff, we had to turn lights off, went even just to be examined and stuff, in the dark, believe it or not. So doing that sort of stuff actually caused me to like vomit or have headaches and migraines that lasted like weeks, and I couldn't sleep for weeks sometimes. It was so bad, but now 3 years later, I'm now starting to talk about doing different vision or light therapies and stuff, which is kind of on the extreme end, but like,
Life changing?
yeah, well, I haven't started therapy yet, that's part of why I'm here, but like, it's just, I think what I'm hearing is very individual, case by case, and
Individual case.
reassessment along the way.
Case by case, and again, what I always encourage people to look at is like the spoon theory, and we'll use the term points for that, is are you spending it on things that are assisting you in your quality of life, or are you getting triggered by things that aren't necessarily? And this is also a point that I cover in another workshop more for professionals, but it's important for you guys to understand too. There's a big difference between habituation and rehabilitation, okay? So for example, if walking hurts your knee, the answer is not necessarily more walking. All right, it depends on why your knee hurts. If it's a question of you actually just need to strengthen your legs for walking, then sure, more walking might not be a bad idea. But if it's actually you've got a torn ligament in your knee, more walking is not necessarily the answer. And so unfortunately, a lot of people in the head injury world will think that if reading is hard for you to do more reading, okay? If screen time triggers symptoms, do more screen time. If whatever triggers symptoms, do more of what triggers symptoms. It depends on why your symptoms are being triggered. So, if reading triggers symptoms because the eyes don't work well together, more reading is not going to fix that. All it's going to do is continue to drag the person down and spike symptoms. Yeah. It's about addressing some of those underlying things. But when it comes to where people spend their energy, we always really do encourage people, look at the things that bring you joy and meaning, and try to spend your energy on the things that either bring you joy and meaning and or are positive in your overall recovery, rather than sometimes things that are just distracting, but don't actually assist you in one of those 2 areas.
Makes sense.
Yeah. Cool. Well, thank you very much, guys. This has been lovely. If anybody wants to try out the funky goggles, again, please not anyone who's injured.